Good morning.
Are you
Morning.
ready? Are you ready? And just try to help me to remember the names because it is a 40-year experience of medicine. So I can see Fatin, Aliyah, and one Noor, Shamimi, and Zandra, Maisara. Good. Zahra,
Yes, doctor.
Fat, Fathul Hakim. Fathul Hakim, mashallah. Fathul Hakim.
Yes,
Is Ibrahim. Who else? I cannot read the name for the other, for the remaining. Okay, come down, please. Okay, no. Who is the remaining now? Yes, it is Aslan and Ali and Nisa. So are you 9 or 10?
9.
9. Okay, so we have now one extra, which is maybe our Farah. Good, good. So let us start by Al-Kitab. بسم الله الرحمن الرحيم الحمد لله رب العالمين الرحمن مالك يوم الدين. Today we are talking about the procedure, yes? I
Yes,
send
doctor.
a sample for you with your colleague Aslan, I think. Did you give it to the group or keep it on your own?
To the group that
You are my mentee group, yes?
Yes.
So it
yes.
is better to have group together for anyone need to ask for anything, any declaration, any problem, any help, I am welcome. You can just add me to the group if not done before. The other thing, I know I sent the previous one for you just to know that speaking about procedure, it have a big references and the endless of knowledge. So it is good for everyone to prepare, but I need you to be touching the clinical points. So when you come to the hospital, you will remember your first priority, okay? So let's go now. Who will be the first one to present?
Wait, sorry, doctor. I still loading the slides.
Okay, don't worry, take your time. Introduce yourself and tell us what you are going to present. And if you need any help from anyone, anyone has trouble, he can send it to other colleague who can present it for him. We are one group, even we are socially distancing.
Fatin, okay. You want me to present? Yeah.
Can you see the slide?
Yes.
Okay.
We see a lot of good colors. Okay.
It's the slide thing. I cannot. Okay. Yeah. The first one is me, right? Okay. Assalamualaikum warahmatullahi wabarakatuh to Doctor. I'm going to be the first presenter, and I'm going to present about nasogastric tube. So next, next. Ajar start ke?
Ya dah gerakkan slide. Oh, sorry.
Yeah, okay.
Or should I present while waiting for Yaya's internet to get?
Okay.
Okay. So what is nasogastric tube? Is a procedure in which a thin plastic tube is inserted into the nostril toward the esophagus down into the stomach. So there is indication and contraindication. The indication for nasogastric tube is feeding and administrations of drugs, especially for infants and children who are not able to take in enough calories by mouth, and for older children who are unable to eat by mouth. The second one is gastric decompression. The third one is prevention of vomiting and aspiration. When there is presence of obstruction, for example, there is volvulus or interception, then this can block a normal passage. And then fluid or food be the passage can be blocked. There will be abdominal distension, can cause pain and nausea, to vomiting, and this to high risk of aspiration. So it also can be used as assessment of upper gastrointestinal bleeding. It also can help in aspirations of gastric fluid. So contraindication is you cannot use the nasogastric tube. There is nasal surgery or severe mid-phase trauma because there is possibility of inserting the tube intracranially. So you might want to for alternative like oral gastric tube. It's alternative. Next. So the procedure of inserting an NG tube revolves around preparation, positioning, procedure for insertion, purpose, and post-procedure or documentation. Next, we start with preparation. First, we have to gather the relevant pieces of equipment in order to minimize the anticipatory anxiety, especially child. So the equipment is as listed in the box, the first box. Second, you have to wash your hands and don PPE if appropriate, so that to minimize the infectious. You have to also introduce your patient or guardian and road. Next, this is we have to prepare the apparatus early on. So this is the tab for the nasogastric tube. So nasogastric tube size is patient's age. To calculate it is to add 16 to the patient age in year and then divided by 2. So you might find a suitable. Next, continue on. You have to confirm the patient name and date of birth, and then explain clearly about your explain clearly the process. You need to explain the goal, time, and expected outcome. If the child can understand of understanding, then you might explain it in a simple word to the child. Obtain informed verbal consent prior to the procedure and document in the healthcare record. You might want to check for any presence of allergies to the latex or any pain before continuing with the clinical procedure. And make sure you've done this in an appropriate location so that you will preserve bed space, safe environment, so that it doesn't disturb the child's bed with painful experience or unpleasant procedure. Really, it's not painful, it's just unpleasant. It's not that comfortable. Okay, next, positioning. We go to positioning. First, a member of staff may be required for the infant or child during insertions of the tube, or you can just ask for the help from the parent. This procedure can be uncomfortable. You might think about pharmacological interventions such as or if the child is much more older, then distraction mechanism can be used, like playing with action toys or guided pictures or bubbles. You might to put the patient in a position in the picture where if it's the shape or cuddly, then you have to hold it tightly. And then if it's toddler or child, you should be positioned in the sitting position as stated. Youngster in the sitting position, securely held by their carrier. Help facilitate correct tube placement and allow the child to maintain some sense of control over the procedure. So here it is important to gain the cooperation from the parent, as it is considered as therapeutic holding, because the child is much more comfortable with parents rather than nurse or doctor. The child should not lean forward, nor should the neck be extended during the procedure. Okay, next is procedure for insertion. The first step is you have to measure the length of insertion and also record the length. First, you have to measure the tube from the tip of the nose to the bottom of the earlobe and to observe between the xiphoid process and the umbilicus, as shown in the picture below. The one should be noted in the child's clinical record. Next, this is a simplified overall picture of how to measure the length. Next step is, if you can see, maybe can zoom in. Okay. The next step is you have to lubricate the end of tube with water-based lubricant or activate lubricant of silicone tube. The third step is examine the nostril for patency to determine the best site for insertion. If the patient is age appropriate, then you might ask the patient if there is any problems in either sides of the nose, if there is blockage, sinusitis or so on. Step 4, gently insert into the nostril and advance tube posteriorly, aiming to tube parallel to the nasal septum and superior surface of hard palate. Advance the nasopharynx, allowing tip of the tube seek own passage into the esophagus and stomach until measures marking is reached. Step 5, you can to tube insertion much more easy. You can insert or encourage them to swallow so that you can advance the tube easily, or you can give them a glass of water for them to sip the water. Step 6, observe the use or chafe, excessive gagging, coughing, wheezing, apnea, or color change during the placement. This may indicate passage of tube into the trachea. Then, if suspected that there is misplaced, they have to withdraw the tube and will advance once the child is stable and comfortable. Lastly, if resistance is met, withdraw the tube 1 to 2 cm and rotate it slowly with downward attention directed towards the closest ear. Never force the nasogastric. Okay, next we proceed to the process for confirming placement. Step 1. Note the external length of the tube at call back. I have said how to measure the length of the tube, and you have to mark where the length that you have measured. So you have to note the external length of the tube, the remaining external length of the tube. Then you gently aspirate a small quantity of gastric fluid from the nasogastric tube with the smallest practicable syringe size, and check the pH using the pH indicator paper. 2. Aspirated stomach content usually have a pH of 1 to 4 and is considered safe. There is a certain circumstance where pH of the stomach cannot be depends on. For example, if the patient is on inhibitor. Then step 3, ensure the external length of the tube remains unchanged from step 1. Anchor the remaining of the tube with tape, brown tape ke hypofix and secure to the patient's clothes. Step 4, consider an extra prior to commencement of fits on all new insertion in at-risk infant or child. pH testing and give false negative information of placement in the presence of acid separation therapy. This is the thing that I mentioned before lah. So the patient at risk infant and children that we consider again to depends on the pH or not is patient who on gastric acid pump inhibitor, on gastric pump continuous feed, with diminished or absent gag reflex, with altered level of consciousness. So next, this is the picture where you anchor the remaining with brown tape and then secure the tube remainder to the patient by using large or tape at the back of the clothes. Next, this is an X-ray done where to confirm the location, and they found there is coiling on the gastric tube due to presence of fistula. Next, okay. Before I proceed to this slide, just want to include that after confirming the placements of the tube, you have to document a post-procedure orientation. The post-procedure is like you comfort the infant or child, dispose all equipment, then note the type, size, and external length of the tube, and you document it. All the patient document the tube type, size, date, aspirated amount, pH, and color in the healthcare record, and document the observation of patient's observation in the flag observation chart between the flag observation chart, and then to notify relevant officer if there is any problems or abnormality found during the nasogastric tube insertion. So in this picture, it shows an algorithm, simple algorithm, on how checking gastric tube position. Okay, next. So the complication is, most of the complication of nasogastric tube is mostly misplacement, which can cause severe disability and death. So, for example, if you miss it, the trachea, you might have high chance to get pneumonitis for feet being deposited the lungs. If there is intracranial insertion in child with vascular disruption, aspiration associated with tube dislodgement. You have to control the speed and the deliver. The tube, the nasogastric tube, is used to deliver medication and also food. This tube tend to be dislodged easily, so you have to irrigate it from time to time. So if you didn't check for the patency of the tube, then there might be a dislodgement and can cause the risk of aspiration. Next is trauma to the sound tissue, especially for the tube, which is hard and stiffer tube. It can cause erosion or necrosis, sinusitis, and otitis. So if you know that the procedure is you need to retain the nasogastric tube for a long time, then you have to choose a suitable nasogastric tube, which is much more softer and flexible, like polyurethane or silicone tube. Pneumothorax and poor absorption of medication given via tube and diarrhea. Poor absorption via tube is due to basically there's the problem is with the compatibility of enteroforaminal and medication that affect the drug concentration. It also bypass a few GIT tract when you put the tube, so the absorption surface is decreased. And then how it can cause diarrhea? Continuous infusion can raise the gastric pH and form bacteria overgrowth that can cause diarrhea. Okay, that's all for me. Thank you.
Okay. Thank you for a nice presentation. I would like just to give a simple comment. For any procedure, there is a fixed point. You must introduce yourself. You must get permission, okay, and the consent of the family. Anyone is not using a microphone, you can please mute it. One using the microphone here. Number two, the infection controls are very important for any procedure because we are not allowed to cause any harm. So infection control rules must be obeyed in everything, like a religion for us, because Islam prevents us from causing any harm. It is allowed for us to give benefits, but not to cause harm. So knowing the complication, even in a simple procedure which you are doing every day, is very important. Like this OGT tube may be very simple and it is done sometimes even by the staff nurse in behalf of us like that, but we must take care because if the patient are very small, is susceptible, extreme preterm, even if you are rough, you can do trauma to the esophagus, to the stomach, you can cause perforation. So it is very important to be soft touch in your medical practice, please. Don't have a harsh hand, please. Try your hand to be soft. The other thing is the confirmation of the patient and his side. It is a rule. Anytime you are going to do procedure, you must confirm with the patient by his name and his file number, not to get mistaken. And even if you are going to do some procedure, which side, like you are going to do ICT, like the surgeon, if he's going to do operation, it is not allowed to go hurry and then cause harm. So identify the patient and identify the sign, the site, and make sure about the complication which can happen. Ask yourself if there any complication. Okay. The good point, your colleague just give a simple referral for that. Sometimes this OGT tube can be used as a diagnostic one. Okay. If I pass, especially for neonate, if I pass it through the nostril and it doesn't pass, it means that there is choanal atresia in both sides. Okay, if I pass it to the esophagus and it returns back and appear in the X-ray that it is coiled and coming out back, I will diagnose esophageal atresia. That's why using one catheter during birth is very important. Usually during suctioning, we suck the mouse before the nose. So sucking the mouse and make sure it can pass down, and then sucking the nose, make sure it can pass. And the last one, even to bypass it through the anus to make sure that there is no anal atresia in any newborn. Okay? I hope you are limiting our presentation for everyone between 10 to 15 minutes. Can we please? So everyone can get his opportunity to present. Okay, go ahead.
Okay, Assalamualaikum warahmatullahi wabarakatuh. I am Anis Arisha. So I will continue to present about central line or central venous catheter. Okay, next. Okay, for central line, we have four type based on the location of the insertion site, which are at the femoral vein, internal jugular vein, subclavian vein, and peripheral inserted central catheter, or known as PICC. Next. So for indication of the central venous catheter, when the child is seriously ill ventilated and has difficult peripheral vein access, because we want to administer the fast fluid for resuscitation. And also for emergency resuscitation that require administration of large amount of the fluid. Next, for the central venous pressure monitoring, especially in hypotension patient. So, next for the pulmonary artery catheterization. Next for the frequent blood draw, because we want to avoid the patient from having pain due to frequent blood drawing. And then for long-term intravenous infusion, for example, when we want to administer total parental nutrition, concentrated solution, or vasoactive substance that can cause the vein become sclerosis. For example, chemotherapy agent, hyperosmolar saline. Next for hemodialysis and apheresis. Next. So for contraindication in central venous catheter, when there is absence of trained doctor for this procedure, because for this procedure it is considered high risk due to high risk of infection. And also when a patient has distorted anatomy or landmarks. Next, the patient has bleeding and clotting disorder. For example, thrombocytopenia, coagulopathy, on anticoagulant, on thrombolytic therapy. Next, it is contraindicated if the patient has a skin lesion, for example, infection such as cellulitis, dermatitis, and trauma such as burns and abrasions. Next, the condition that can cause the patient has high risk of sclerosis and thrombosis at the vein. For example, vasculitis. Uh, Next, the thrombosis of the target vein. Next. Okay, so in pediatric patient, the commonly used central catheter is femoral venous catheterization because it is most commonly accessed central line site. Which for the ventral venous catheter, it is easy to access because it has large vein compared to other vein, and it also distant and also far from the major site of activity during resuscitation. Okay, for example, in resuscitation, we will do intubation at head and neck, and also the CPR at the chest. Yes. Okay, so before we proceed to do this procedure, firstly we need to obtain the consent from the parent first, which we explain about this procedure, how it was done, and also explain about the complication that will occur, such as infection, bleeding and thrombosis. So after we have obtained the consent, we set up the equipment. For example, sterile Seldinger cannulation set, tissue dilator, lignocoin, skin prepper solution, and also sterile dressing. Next. Okay, so this picture shows the equipment that we need for this procedure, which we have dilator, we have the guided wire, needle. Okay, next. Okay, so next. Okay, so to do this procedure, we need first we need to put the patient in the supine position first, and raise the hips slightly to flatten the inguinal area, but place the towel under the hips. So the hips and knee are slightly in flat position because we want to expose the vein. Okay, for needle incision. Next. Okay, so for the landmark, okay, so for the landmarks of the femoral vein, firstly we need to find the femoral artery first, which femoral artery is located at the mid-inguinal ligament. So the femoral artery can be confirmed by we feel the pulsation on the palpation, and then after we have find the femoral artery, we move the fingers 1 to 2 centimeter below to this position. So basically the femoral vein is located medial to the femoral artery. So by using index and middle finger, uh, finger, okay, middle finger to locate the distal and proximal portion of the femoral artery. So medial to the fingertips is the cause of the vein. So we should puncture at this site. However, it is recommended to use ultrasound guidance because we want to avoid from having arterial puncture. Okay, next. Okay, so for the so what why we need to use ultrasound, because in ultrasound it can visualize the dimension and position of the femoral vein in relation to the femoral artery. Uh, so in this procedure, we keep the ultrasound device in sterile glove. Uh, uh, so when compress the vessel with the ultrasound, the vein become collapsed with the tip of the needle, while the artery is still pulsating. Okay, next. Okay, this picture shows the ultrasound where for this procedure. So as we can see, for the vein become collapse when we press with the ultrasound. Why the artery is still in pulsation? Next. Okay, so for the incision technique, before we need to clean the inguinal agent by using iodine and 30% of the alcohol. Next, we infiltrate the local leader coin at the side of the skin incision because we want to avoid the patient become pain that will cause difficulty for us to do this procedure. Okay. Next we need to no. Next before previous slide. Okay, so for the femoral artery, we still need we still need to palpate. Why do we need the incision? So the needle is insert at the 30 to 40 angle towards umbilicus. Next. Okay, so in intracentral catheter, we use cell digger technique or catheter over guide wire technique because we want to minimize the displacement of intravenous catheter during incision. Next. Okay, so first, for femoral vein incision catheter procedure, as the blood is aspirated, we disconnect the shrink from the needle. Next, insert the guide wire by the needle. The guide wire is gently insert into the needle. Then we withdraw the needle gently to prevent the guide wire from displaced. So using the scalpel, incise the skin at the puncture site while avoiding the guide wire because we want to administer the dilator. Next. So insert the dilator over the guide wire and advance slowly through the incised puncture site. So remove the dilator while maintain the guide wire position and advance central venous catheter over the guide wire. Next. We aspirate and flush all the lumen and reclaim and apply the lumen caps. So you using the needle holder and seek suture the catheter in place because we want to avoid it from displacement. Next, we dress with next we put the dressing. We put the dressing and also tegaderm to allow the insertion point to be clearly seen because we want to monitor for any infection site. Uh, any infection at insertion site. Okay, next. So the complication it can be divided based on during or with catheter placement. So for during catheter placement, there is risk for arterial puncture, local hematoma if it's punctured at the artery, bowel or bladder perforation, air embolus, catheter embolus, arteriovenous fistula, and pseudoaneurysm. So by placing the catheter, there is risk of infection, swelling of the lower extremities, deep vein thrombosis, catheter knotting, and catheter malposition. That it can injure the lumbar venous spaces. Next. Okay, so the complication from the central venous catheter is central line associated bloodstream infection, or known as CLABSI. The definition of the CLABSI is laboratory confirmed bloodstream infection that not related to an infection at another site that developed within 80 hours of central line placement. So basically, the most common clinical feature is the patient will have fever and chills, sepsis, has sign of inflammation at the insertion site, such as pain, swelling, erythema, discharge at insertion site. So to prevent the clepsy from formation, that's why we need to perform hand hygiene before doing this procedure. And also apply appropriate skin antiseptics and ensure the skin preparation to become completely dry, and use all the sterile barrier precaution such as sterile gloves, sterile gown, cap and mask, because we want to maintain the sterile condition in placement of the catheter. Next. So once the central line is in place, we need to advise the patient to follow recommended central line maintenance practice, such as the patient needs to wash their hand with soap and water, or using an alcohol hand rub before and after touching the line. Next, remove the central line as soon as it is no longer needed, because the fast we remove the catheter, the less likely for infection to occur. Yes. Okay, so we have finished with central venous catheter. Next, under central venous catheter, we have long percutaneous line insertion. Okay. So what? So the long percutaneous line insertion is a very fine tube that is straight up a small vein in the arm or leg until it is in large vein, which is vena cava near the heart. So basically, for the long percutaneous line insertion, we insert the catheter at the peripheral. Yes. The indication of long percutaneous insertion is for the patient with limited peripheral access, for long time intravenous medication administration, for example antibiotic, and then to continuous administration of the drug that can irritate the peripheral vein, for example vasoactive drugs such as epinephrine and chemotherapy drug. And then for frequent blood draw, next to administer the total parental nutrition, for example in the very low birth weight baby, because this baby has delay full enteral feeding. So for the contraindication, it is not allowed to insert at the patient has burn, trauma, skin infection, radiation, or has history or current of venous thrombosis at insertion site. And then for the patient has active bacteremia because risk of infection. And then for a patient has chronic renal failure and end-stage renal disease, because we want to maintain this vein for dialysis catheter placement. Then for patient has coagulopathy. Lastly, it is contraindicated for patient has persistent cough and vomiting, because there is increase of the intrathoracic pressure that can cause the catheter to become malposition, erosion, or cardiac tamponade, if it is malposition into the heart. Next. Basically for the long percutaneous line incision, it can insert at any site. However, the common site to be placed is at the large vein in the antecubital fossa, which we have cephalic, bacilli, and medius cubital vein. And then the at long saphenous vein at the medial malleolus, and then for superficial temporal vein. However, for the superficial temporal vein, it is not recommended to be done. Yes. Okay, so for the incision distance, before we insert the catheter, we need to measure the length of the long line. The long line. Long line. Okay, for example, if we insert at the lower lid by 8, we need to ensure that the tip of the catheter is reached at the xiph sternum, and sternum, and then for the arm, it we need to ensure that it will reach the sternal notch, which the side of tip is basically in the vena cava. Next. Okay, so under long percutaneous line incision, it has PICC, which peripheral inserted central catheter. Okay, next. So for the type and PICC components, uh, the commonly used catheter is based on the age of the child, such as for the preterm, we use one French, term to French, children third to fourth French. Okay, next. Okay, so the equipment that required for the long percutaneous line incision is has been stated, which we need long line pep, shrinks, cleaning solution, coin. Okay, next. Okay, so basically there is the equipment that we need that is similar with femoral vein catheter. Yes. So the procedure, basically for the procedure, it is similar with femoral vein catheterization. However, in PICC, commonly we will suture the incision site, or we only put tegaderm. Yes. So after we have put the catheter, we need to confirm the position by check the location of the tip using chest X-ray. So the line of the tip should be sighted outside of the right atrium. Okay, for example, in the upper limb placement, it need to be located at superior vena cava, which is above T4, and lower limb placement at inferior vena cava, which is located lower to T9. Okay, then by using chest X-ray, we can check whether the tip is misplacement and malposition. Yes. Okay, so this picture shown the central line incision that we check using the chest X-ray. So at the right side, this picture show the location of the central, which it is located at the superior vena cava. And then while at the left side, it shows the central tip has enter into the left atrium. So we need to withdraw it urgently, because if the catheter is inserted into the heart, it has risk of cardiac arrhythmia. Next. Because for the maintenance of the catheter, we need the insertion site with the Tegaden dressing should be left undisturbed, and frequent flushing of the line with saline and heparin contained solution to avoid the bacteria from that side. Next, the sterile dressing replace at regular interval and remove the catheter as early as possible if not indicated. Next. So the complication that occur is infection, catheter malposition, or migration if we use Tegaden only, and then catheter occlusion due to thrombosis and non-thrombosis, and the complication that we afraid is cardiac arrhythmia. Good, so that's all for central venous catheter and long percutaneous line insertion.
Okay, anyone need to ask here any questions? Okay, so it is a very important point, please. If you open your logbook, you will find the 3 levels of procedure. OAB is O is observation, A is assist, B is perform. So it is very important to know. Now even we are getting theoretical knowledge, but we need to observe. And for some like very professional procedures, you will find a limited stuff. I hope all of you, inshallah, with time will be able to have baraka in your hand so you can do all of that. Like this one, we has Dr. Said Khalid is very professional in that. When I went to USM, there is Dr. I think, Noor, I will remember the name. There is, in every hospital, you will find someone who is a very, very meticulous in that point. I hope I see, inshallah, all of you are a good figure when there is a problem, when we cannot cannulate the patient, because sometimes you may miss the patient, or you need to transfer him to other area if you are not able to secure that line. Yeah, I think it's Dr. Noraida in USM. We have in Mecca, we have a very famous name like that. So it is very important to know that any procedure you must be prepared theoretical, then you must observe, then you must assist, and then you must try, and the last step to teach the others. Unfortunately, in some area of the world, everyone is very good in certain skills. You need to keep it for his name, just to be famous by that. It is not good. You must try to give the chance for others to be taught upon you if you are the most skilled one. Okay, this one now I think it is kept only for the senior MO. Inshallah, you will be good for that. We know that to secure airline is very important, but here the infection control is the top important, because you are going up to the major vessels and hearts. So if you just come with bacteria, it means you will go for septicemia, infected endocarditis, whatever. Okay, if you make it around, you can perforate a major vessel. If you didn't follow the regulation like any central line, must have continuous dripping of the IV fluid, even 1 ml per hour. Otherwise, it will be clotted, and this clot can be moved and cause a thrombus. So even before, during, and after, we must be good, knowledgeable, and aware about any suspected complication. Okay, thank you. Let's go for the next presentation.
Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh. Okay, so I will present on chest physiotherapy. So chest physiotherapy is therapy to
Everyone
mobilize.
mute his, please, his microphone.
Sorry.
Okay. There is some voice. Anyone, everyone, please mute his microphone and let is alone speaking.
Is there any more voice? Maybe raining? I'm not sure. Okay, I proceed. So, chest physiotherapy is therapy to mobilize the pulmonary secretion. It includes chest percussion, vibration, and postural drainage. And after these procedures, after this technique of chest percussion, vibration, and postural drainage, it is followed by productive coughing by the patient, or suctioning of a patient who has a decreased ability to cough. Okay, so the indication for chest physiotherapy is to stimulate productive cough and improve aeration in patients with disorders that result in mucus production. For example, cystic fibrosis, pneumonia. In this infection, the patient produce excessively excessive mucus than normal. So in normal person, the mucus is just enough, like need to keluarkan, not need to make it out. But for patient with especially in cystic fibrosis, it impair the air entry. So we need to stimulate the cough to improve the aeration. The other is bronchiectasis, atelectasis, and bronchiolitis. Okay, the contraindication for chest physiotherapy is unstable head or neck injury, because we will move the patient, and then active hemorrhage or hemoptysis, recent spinal injury, and rib fracture. So before we do the procedure, we need to assess the patient's lung, listen for any wheezing, crepitation, and equal air entry. This will will guide us where we would do the chest physiotherapy. If for example, when we check right and left lung, we can hear reduce air entry at the left side, so we focus the chest physiotherapy on the left side, like that. The second thing is we assess patient's ability to be placed in different position, because the ability, I mean, with lines, tube, IVs, because these can disrupt our positioning of the patient. And next is baseline vital signs, baseline pain score, and also explain procedure to patient and family, because parents might be anxious when they hear the percussion sound, the clapping sound. They might think that this procedure is hurting their child. So we need to explain the procedure properly to the parents, and if the child is old enough to understand, we need to explain the procedure to the patient. So the first technique is percussion, or cupping or clapping. This is rhythmically clapping on the chest wall over the area being drained to force secretion into larger airways. So the hand position is like in the picture. We position our hand so that the fingers and the thumb touch each other, and the hand are cupped. So the procedure produce hollow sound and should not be painful. For each area, after this, we will see which area we should do this, and it should be 1 to 2 minutes in each area for percussion. Okay, this example of doing on a chart, not a real chart lah, patung. Okay, next is vibration. Second technique is vibration. Vibration is a gentle shaking pressure applied to chest wall with flat part of palm. If just now, in percussion we do the C shape hand, in vibration, for vibration we make our hand flat, and our another hand can help for the press, for the shake, for the pressure applied on the chest. And this vibration also different with the percussion just now, because it's only performed when the patient is exhaling, while the percussion is done throughout the exhaling or inhaling. Okay, so for vibration, after each vibration, encourage patient to cough and expectorate. Next is postural drainage. This the percussion and the vibration is done incorporated with the postural drainage. We will see after this we have 6 position. So for each position we do percussion and vibration. So postural drainage use the principle of gravity to facilitate the drainage of secretion from bronchial airways to be coughed up easily. So the 6 position, the first one is anterior segment of upper lobes. To drain this segment of upper lobe, patient is in supine position, and the area that we percuss and vibrate, do vibration, is above between nipple line and clavicle line, as in the picture in the circle. Next is posterior segment of upper lobe. The patient, for the right side, patient can stay flat. It's like left lateral. And for left side, the back is up higher, and the area that we percuss and give vibration is between spine and axilla, as in the picture. Next is anterior mid lung. For this position, for this posture, patient is about 10 degree slope downward, and the area that we percuss and give vibration is the nipple line. Next is anterior bases of lower lobes. The patient is in supine position, or also for anterior mid lung just now we put pillow underneath the patient to give more comfort and ease the procedure. And for the anterior bases of lower lobe, we also put the pillow. The patient is in supine position. The area that we percuss and give vibration is below axilla at lower ribs. Next is lateral bases of lower lobe. The patient is sit like this, lying like this. It's like not fully left lateral, and we percuss and give vibration at the axilla, at the mid axillary line. And next is posterior bases of lower lobes. Patient is in prone position, and the area that we percuss and give vibration is beside the spine. We should not percuss on the spine. And for all this position, it is done 1 to 2 minutes for each area, and it is done for example right for 1 to 2 minutes, and then to the left side for 1 to 2 minutes. Okay, during when we do the procedure, we should also note the vital sign of the patient, the oxygenation of the patient, positioning tolerance, whether the patient is comfortable with the position that we move the patient, that we position the patient, And then percussion and vibration tolerance is then like the patient become hurt, it's painful. So we should take note of that, monitor all that, the cough of the patient, ability to move secretion, and the comfort of the patient. So post procedure, again, we also assess the patient tolerance to the procedure just now, and we suction any secretions. For the secretion, we note the color, consistency, odor. This suction for any secretion, especially if the child cannot cough by himself or herself. We also repeat assessment of lung sound. We hear the wheeze, the air entry, to assess the progress from before the procedure and after the procedure. And next is vital sign. So if suction is needed, we aspirating secretion through a catheter connected to a suction machine or wall suction outlet. So the site is nasopharyngeal. We enter through nose or oropharyngeal, or we can enter more deeper endotracheal or tracheostomy. So indication of chest suction just now is evidence of unable to cough up and expectorate secretions. The other one is sign of respiratory distress. Next is obtain sample of secretion for diagnostic purpose and to prevent infection. Because when we do the percussion, the vibration, we mobilize the secretion just now up to the upper airway, and sometimes because the patient cannot expectorate by themselves, the mucus stay at the back of the mouth, at the back of the neck. So we see that, so we suction the mucus. So complication of this procedure, patient might be oxygen desaturated during the procedure, pain or injury to patient's rib, muscle or spine because we do the percussion just now, and then vomiting, aspiration of oral secretion into lungs. For this aspiration of oral secretion into lungs, that's why we should not do after the feeding directly. Uh, Supposedly we do before the feeding. If after the feeding, I don't remember the hour. I think about 3 hours after the feeding to do this procedure. And next complication is hypotension. Okay, that's all for me. Actually, there is a video that we can see on this. Do you want to?
You can share it to the group.
I open it right now.
Better to share because time is now running. Okay. So your colleague give us an important also point. Medicine now is not a doctor and a patient. And your job in the future, inshallah, you are working like a team leader. We have now known as multidisciplinary team. Multidisciplinary team, it means the patient needs service by many specialty. You will be the one who arrange that, and you must know the detail of that. It's a very good point here in Malaysia that the treating physician must know every detail about the situation and the patient and the instrument and like that. Okay. So please remember always that therapy, occupational therapy, whatever we are doing is very important to be oriented about all details of that. Because sometimes you are the treating physician, you must be able to illustrate to the family again if they need to do some physiotherapy at home or like that. So it is better to come from your side. Okay. Very good. Any, or we can go for the next presentation. Okay. Thank you. You can put the title for this great and
very good morning.
You can put this is the anthropometric measures and vital signs.
Yes, doctor. I'm sorry.
You can put the title here, anthropometric measures and vital signs.
Okay, yes. Okay, so I will correct the title later. So today, for my part, I will present two topics. First, anthropometric measurements, and the second topic is blood pressure measurement. So we go for the first topic, which is the anthropometric measurement, the height, weight, and also occipitofrontal circumferences. So when we're talking about anthropometric measurements, in pediatric, it's very important to take note about their measurement because we want to know whether these children has abnormal growth or normal growth. So we go for the length assessment first. So for the length assessment, it's different for the age group. As you can see, if the age is below 2 years old, which involve infant and also toddler, so we will use length assessment, not height assessment, because the patient cannot stand during this age. So that's why we use length assessment, and the equipment needed is measuring board. So the technique is it's better to have two person because one person can position the children and another person can measure the length, and we need to place the baby, the children, in supine position on the measuring board, and the measurement need to be reported to the nearest 0.1 centimeter. As you can see in the picture, the child is positioned in supine where the head is held by the person and the knee is straight and the sole of the foot is flat to make sure the accuracy of the measurement. Next slide. For the age group 2 years old and above, so we use height assessment where we use stadiometer. We need to record their standing height. So it is performed without shoes. So the children need to take out their shoes and we take 3 measurements if possible, and we take mean out of 3 measurements to get correct accuracy, better accuracy, and then we plot the measurement into the growth curve later on. For the weight, as for the height just now, it is divided into 2 different age groups. So same here for the weight. So if for the age of 2 years old and below, so the equipment needed is calibrated weighing scale. So the infants will be weighed on the weighing scale without clothing, and if possible without diapers to ensure the proper measurement. And the measurement we take to the nearest 0.1 kilogram. Next. For the other age group, which is 2 years old and above, so as the children can stand, so we use standing weighing scale. So like usually we ask them to remove their shoes and if possible to wear little clothing, and we take the measurement to the nearest 0.1 kilogram and then we plot on the growth chart. So that's for the height and also the weight. Now we move on to the occipitofrontal circumference, OFC. It is also known as head circumference. So this OFC usually is used for children up to 3 years old because during this period, it is the time of where the brain best or develop more. So the technique is that first you use flexible measuring tape. So you measure at the maximum diameter. I repeat, maximum diameter where you put at the supraorbital ridge, which is at the level of the eyebrow, to the occiput, to the back of the head, and you take measurement for 3 times and you take the largest value. And then you record the value nearest to 0.1 centimeter and you plot on the growth chart. Next slide. So for the better view, so this is the picture of OFC. As you can see, we take the measurement from the supraorbital ridge, which is at the level of the eyebrow, up to the occiput. And this is very important whether we want to know if the child has any abnormal head growth or normal head growth. So this abnormal head growth can have two, either macrocephaly or microcephaly. If it is macrocephaly, it is greater than 2 standard deviation above the mean. If it is microcephaly, it is greater than 2 standard deviation below mean. Next, when taking OFC, so it is very important to take notes. First, OFC can be affected by thick hair of the children and also any cranial bone deformation or hyperosterosis. So that's why you need to take 3 measurements and you take the largest one. And the second one, the height and weight should be plotted also. Not only you take OFC, you also need to note about the height and weight because there can be inappropriate or discordant of the body growth. Next one is you need also to measure the head circumference in older children who has abnormal height and weight. Usually OFC is used for children up to 3 years old. But if in the older children have abnormal height and weight, you need also to measure their head circumference. So this is the example of the growth chart from the KKM. As you can see, the blue chart is for boys, the pink chart is for girls. So you can see from this chart is that if the line that you plot, the measurement that you plot on the line is if it is fall into the white color, it is normal. If it is yellow, it can be for weight, it can be undernourished. If for the height, it can be stunted. If it is fall under red, meaning that it is need to take precaution or need to take immediate action, as the child can have extreme overweight or extreme obesity, or in height, it can mean the child has extreme stunting. So that's for anthropometric measurement. Now, I will proceed to the next procedure, which is blood pressure measurement. So next, blood pressure measurement in pediatric, there are a few indications. First, if the child has chronic disease, any symptoms of hypertension, the children is in emergency setting, and any high-risk patient. So when taking blood pressure measurement, it is very important to take note about the equipment. First of all, you can use either stethoscope together with blood pressure cuff with sphygmomanometer, or you can use automatic one known as automated oscillometric device and also the cuff. So when talking about the blood pressure device, you need to take note about the blood pressure cuff. So regarding the cuff, you need to look carefully about the length and also the width of the cuff, because the length of the cuff should be about 80%. So it is enough to encircle the arm of the children, and the width should be at least 40% of the circumference of the upper arm. Why the cuff is very important? The size cuff is very important because if the cuff is too small, so it can falsely record BP height. If it is too large, the BP can be falsely low. So another important point is that to avoid using a cuff with a width that extend over a joint, because it can also record false measurement later on. Next, so this is what I mentioned earlier. So as you can see on the right picture, the length of the bladder, the length of the cuff should be 80 to 100%, and the width should be at least 40% to the circumference of the upper arm. Next slide. So to measure the blood pressure, as we learn, we have two method of measurement, either direct or indirect. So for direct, as the name suggests, meaning that we took direct the blood pressure measurement intra-arterially. So as it is direct measurement, it is the most accurate. However, it is invasive. This direct measurement is only used in intensive setting or any operation setting. So for indirect, meaning that you try to collapse the artery by using external cuff. So there are many ways to do. First, you can do by using manual cuff and also sphygmomanometer. So this manual sphygmomanometer can lead to some errors, which are observer and methodology errors. Example of the errors can be like if the person has a digit preference, number interest to the blood pressure measurement, or there is any hearing deficit of the observer, so it can also lead to errors. Next is the automated oscillometer device. This automatic device is very good. It is remove observer error. However, there are some circumstances where this device also can be inaccurate. Next is the ambulatory blood pressure monitoring, where it monitors blood pressure 24-hour period. So this ambulatory blood pressure monitoring is very valuable as it is used in case of where you suspect any hypertension case. Like for children, usually they can have white coat hypertension. So it is good to use ambulatory blood pressure measurement. Next is the Doppler ultrasound. So this blood pressure monitoring using Doppler ultrasound technique is useful for systolic BP. However, it is unreliable for diastolic BP. Next. So when we're talking about blood pressure, we also need to talk about Korokov sounds. So we know that this Korokov sounds is originated from the combination of the turbulent flow as well as the oscillation with the artery wall. So these Korokov sounds have 5 phases from phase 1 up to phase 5. So as you can see in phase 1, it begins when you start to hear the clear tapping sound. So this indicates systolic blood pressure. And then when you go to phase 2, you start to notice that the sound becomes softer and longer. And going on to phase 3, where the sound becomes crisper and louder. And coming to phase 4, when the sound then becomes muffled, becomes slower, as it is start to alternate with diastolic blood pressure. And at the phase 5, when you will notice that there is complete disappear of the sound. So this phase 5, when the sound completely disappeared, it indicates diastolic blood pressure. Next. So some tips to ensure the correct measurement is that first, the patient need to avoid any consumption of the caffeinated beverages. So if the children consume any caffeine such as coffee or tea, so you need to, within the past 30 minutes, so you need to delay before getting the BP measurement. Next is no restricted clothing over the upper arm. So meaning that the arm need to be free in order to get correct measurement. So you can roll up the sleeve. And the third one is do not place the cuff on a limb that used for any IV or any intra-arterial infusion, or if the arm has any fistulas. So if in a case where there is full of this insertion at the upper limb, so you can use lower extremities to get blood pressure measurement. And then you can also palpate brachial artery in order to ensure it has viable pulse. And also the important point is that regarding the position. So you need to position the arm properly at the level of the heart so that it get better measurement. If the arm is above the heart, the reading can be low. If the arm is below the heart level, it can be high reading. So that's why you need to position the arm at the level of the heart. Next, ideally and of course, you need to make sure that during BP measurement, either the performer, either the doctor or the patient should not do any talking, any chit-chatting, because it also can affect the blood pressure. And you need to hold the dial so it faces you directly, meaning that the blood pressure measurement should be face the doctor, and avoid any slow or repetitive inflation of the cuff, as this can produce venous congestion and can cause false readings later on. Next. So the technique of the BP measurement. So first of all, when the patient comes to you, you have the patient to sit, or you can have ask them to lay down. Make sure they are comfortable, relaxed, leg uncrossed, feet resting on the floor. If it's children, they can sit on their parents' lap 5 minutes before starting the measurement. And as I mentioned earlier, the arm need to be at the level of the heart and slightly flex at the elbow. And then you place the BP cuff over the brachial artery position, and you make sure that the lower border of the cuff should be 2.5 centimeter above the antecubital crease. So first of all, you need to know the inflation level. So we need for the inflation level determination. So you palpate the radial artery and you start to inflate the cuff, and then until the pulse disappear. So you noted this pressure and you add on another 30 millimeter mercury to it. And then you deflate, and then you wait, and then you start to put your stethoscope over the brachial artery, and you start to hear the cough sound from phase 1 up to phase 5. So you know already the inflation level. Next, when you already know the inflation level, so you inflate the cuff rapidly to the predetermined inflation level, which you have done earlier, and then you turn the bulb screw counterclockwise in order to deflate it at 2 to 3 millimeter mercury per second, and then you try to hear the sound with your stethoscope. When you start to hear the sound at the cough phase 1, so it is systolic. When the sound diminish, disappear completely, it is cough phase 5, diastolic BP. And then after you hear the phase 5, you deflate the cuff rapidly, and then you record the systolic and diastolic level to the nearest 2 millimeter mercury. So when recording the BP, it is not you are not supposed to record only the BP, but you need to also record the which arm is used, the arm position, as well as the cuff size used. And if you want to repeat the measurement, wait for 2 minutes and then you can repeat it again. So I think that's all for the procedure. Thank you.
Any question about this essential parts and very important? Okay. Yes.
Doctor, I actually have a question. When I do this anthropometric measurement, we know that if the children is 2 years old and below, we do length assessment. But 2 years old and above, we do height assessment. But if the child cannot stand, so of course we need to proceed with length assessment. But do we take normal assessment or do we have any formula for that?
Shamini, you must be very flexible.
Yes.
Very flexible. You must be very flexible. Sometimes the child can stand, but is coming to us by injury or accident. You must stand up to know your length, because all medical emergencies now they are driving the length. So just you see, inshallah, if you are coming to advanced you will find like one big folded paper with the length, this up to 110, this 120, this like that, and everyone puts the dose of the emergency medication according to the length. Unless you are going to the weight. So you must be flexible. Of course, the child is cerebral palsy in accident. Sometimes it may be just a child 1.5 years, but he is very competent and he can stand like that. We can accept, but this is a general rule. So general rule is done to help us, not to make our life more difficult. The most important point for her presentation, which as I said, it is very essential. Because for Untitled Chapter, we are not accepting single measure. And I think if you attend with me the growth and the development in the 3rd year, I said it may be one mother bring the 2 mothers came on the same time. Both of their children are on the 5th centile, 50. But when you go through the previous measure, you will find one child was 89, and the other one was in the 5th centile. What you will tell the both mother, it is the same message, your baby is on the middle and he is okay, or there is different evaluation. What you will done when it's the same message, feel happy, your baby already on the 5th centile and everything is okay. Of course, no. The first patient I will say, oh, your child was 98, so he crossed more than 2 centile, it is dangerous. We must investigate. It may be the first one, or hopefully our treatment and the intervention and the nutritional program make a good difference. Okay, so that's why we need it to be repeated centile chart. So I just remember if someone who is getting height or weight or its circumference is doing the job by, what to be said by Arabic, by some neglect or some unhappiness, he just put the baby on the scale and remove him and go. It is like that. And then you got an odd measure. Come, he told me this child, the previous visit, it was 104. Today he is 99. That's why if you did a wrong measure, you are making trouble for the practitioner. So please try to be very, very meticulous. And for the vital sign, you must know it because of two things. Its name. Its name is vital sign. And remember that vital signs are vital. And it is very vital to do it correct. Otherwise, you are giving yourself a wrong knowledge which can do a wrong decision also. So remember, please, vital signs are vital, and to do it correctly is more vital. Thanks. Next.
Okay, Assalamualaikum. So today, my part, I will be presenting about lumbar puncture, or the other name is spinal tap. Okay, next. So here are my outline. Okay, so next. Okay, so lumbar puncture could be defined. Lumbar puncture is an invasive investigation where we collect a small sample of cerebrospinal fluid from the subarachnoid space. So this fluid, which then sent to the lab for analyze for red and white blood cells, protein, glucose, as well as any presence of microorganism. CSF could be both diagnostic and therapeutic. Next. Okay, the indication for lumbar puncture, if in terms of diagnostic purposes, we would like to confirm the diagnosis of meningitis or encephalitis, as well as to identify the organism and its antibiotic sensitivity. We also it also helped us to diagnose the immunological infection, for example, in Lyme disease, as well as to diagnose subarachnoid hemorrhage for patients who come with acute headache. Okay, next, we also like to measure the pressure of the lumbar cerebrospinal fluid. And besides the diagnostic purposes, it also allows us to administer therapeutic agent, for example, antibiotic or toxic chemotherapy, as well as to introduce any anesthetic or contrast agent into the spinal cord. Okay, next. So patients who are contraindicated for lumbar puncture are listed as below. So the first one is a patient who is coma or reduced in their conscious state, since they don't have any response to the painful stimulus. Next is patient who come with signs and symptoms of increase in the intracranial pressure. For example, hypertension, bradycardia, abnormal respiratory pattern. They also have altered pupillary response, papilloedema, decerebrate or decorticate posturing. Next, there will be a local infection at the needle incision site, as well as thrombocytopenia. Next. So the equipment. Next, for lumbar puncture is as shown in the picture. So we have the antiseptic dressing, which include betadine, and then the ethanol 70%, and then we have the local anesthetic, the sterile glove, the sterile container to collect the CSF, and then we have the syringe and needle, we have the manometer in order for us to measure the opening pressure. So the spinal needle is actually based on the child age. So we prefer to use 20 to 22 gauge. So small hole is preferable because it helps us because it could prevent any CSF leakage. So for the needle length, for neonate, it is preferable to use 1.27 centimeter length. Less than 12 years old, 6.3, while more than 12 years old, 8.75 centimeter. Okay, next. Okay, for positioning, there are two types of positioning. So the first one is the lateral decubitus position. Okay, so as in the picture shown, we place the child on his or her side at the edge of bed with the patient facing the holding assistant. Okay, then we ensure the child to have their knees drawn up towards their chest with their head flexed forward. So in other words, they have to be in a fetal position. So we have to ensure their hip should be as vertical as possible, and an assistant is needed in order for us to hold the patient in this position. A kind note, we have to notice that we have to ensure that there is no compression of the trachea or compromise the lung expansion during the positioning and holding, especially in neonates and infant. So the importance of this position, lateral decubitus position, is we like to widen the intervertebral spaces, so allow us for easier collection of the CSF fluid. Plus, only in lateral decubitus position that measurement of the opening pressure could be done. Okay, next. So next is the sitting position. So sitting position is optional for patients who have potential to develop respiratory compromise if they do hyperflexion of the neck in the lateral recumbent position. So in the picture, for the older children, the child should be seated leaning forward over a bed and prepped with a pillow if needed. So their head and chest are bent forward towards their knees. However, next, for infants or neonates, they are held in sitting position by the assistant grabs the child arms and legs in each hand, and the assistant should support the head of the child in order to prevent any hyperflexion of the neck. Okay, next. Okay, the importance point in positioning is that whatever position that we are choose, it is important to make sure that the patient's shoulders and hips are straight as shown in the picture in order to prevent any rotation of spine. And also we have the importance to have an experienced assistant who can position, restrain and comfort the patient in critical for, it is very important for success of the procedure. Okay, next. Okay, next. Okay. In terms of landmarks, where the needle should be inserted is actually between the L4 to L5 interspaces at angle of 15 to 30 degree. So we mark out the L4 spinous process by joining a line between the highness point of the posterior superior iliac crest. Then as shown in the picture. Okay. Next. So the procedure. Okay, next. So as usual, first of all, we should do preparation. So again, informed consent, and then self-introduction. So informed consent, including the explanation of the technique, the benefit and the complication towards the patient parents. And then we should ensure that we have enough staff, and then also ensure there is enough equipment, enough and functional equipment, as well as continuous observation of the patient vital sign. Then we do the positioning of the patient. It's either lateral, recumbent or sitting position. Next is we have to identify and mark the lumbar puncture site. Okay, then we give sedation midazolam or apply any local anesthetic. Okay, the fifth step is we clean the marked area using the standard aseptic technique, and then we apply the sterile drip. Okay, moving on. Then after the previous steps, we gently introduce the needle into the skin at the identified site, and we have to ensure that it is point towards the umbilicus. So the entry point is below to the spinous process L4. Okay, then, okay, moving on, we gently advance the needle a few millimeter at a time until a light resistant or a pop is felt. So when there is a pop is felt, this shows that we had entered the ligamentum flavum. So then we remove the stylet and check for any CSF flow. If there is no CSF flow, you could reintroduce another stylet and advance more or reposition the needle. Okay, if there is CSF flow, you could proceed by attach to the manometer if we want to measure the opening pressure and collect the CSF in the designated bottles. So then we gently withdraw so after collecting the sample, we gently withdraw the needle, spray with oxide, cover with gauze and bandage, and then ensure the child to lie supine for the next 4 to 6 hours, and then continue monitoring till recover from sedation. Lastly is we can take random blood sugar. So random blood sugar could be taken at the last steps of the procedure or the very early step before doing the lumbar puncture. Okay, next. So the complication for the lumbar puncture is the first, the common one is fail to obtain the specimen. So we have to repeat the attempts. Second is headache, which also one of the most common complication. Next is backache, any cerebral herniation, any bleeding, infection, cardiorespiratory compromise due to the positioning, and less likely numbness and paraplegia. Okay, next. So next, so for the last part is the analysis of the CSF. So for the opening pressure, the normal pressure for child is less than 20 centimeter H2O. So for the appearance of the fluid, we could assess it on the back side to see if it is clear, cloudy, or blood stain. Then we could send the sample to the lab in order to investigate the total protein. So if it is increased, it could indicate any infection or traumatic tap. However, it could be increased for the newborns as their baseline up. Okay, next. Okay, we also should measure their glucose level. So if it is decreased, it should indicate any bacterial infection or any glucose transporter defect. Then we should observe for any red blood cells. If it is present, so it could be due to hemorrhage, traumatic tap, but then also could indicate any hemorrhage infection such as in herpes. So then the white blood cells, we should also analyze for white blood cell. If it is high in total white blood cell, it indicates infection. If it is neutrophilia, bacterial infection. If it is lymphocytosis, it is viral or TB or fungal infection. Okay, next. So this is summary of the analysis of CSF for the normal, for the bacterial meningitis and viral meningitis. So with that, thank you. Any question?
How many bottles you are collecting for CSF?
About 3 to 5 bottles.
Yeah, originally it's 4.
It is for
One. Yeah.
one. Okay, it's for total protein.
Yes.
Okay, and then glucose.
Okay.
Okay, and then
Culture
yes, culture.
and
And then for the cell count and
okay.
differential. And then
For gram stain.
gram stain. Okay.
So we need 4 bottle, but it is very important, inshallah, in the future, if any one of you are coming to do lumbar puncture, you must ask his senior, do you need extra bottles? Because as you present, we may need sometimes a special sample if you suspect viral, like herpes simplex virus. We need the certain tube for TB. We may need some tubes if you suspect inborn errors of metabolism. We may sometimes, if you are thinking about HIV and immune deficiency, you may collect for others. So it is very important to ask your senior. Some situation you may collect up to double of that number if needed. It is better than to put it in the fridge, few drops, okay, 10 drops for every bottle, and you can take decision after that. So when you are doing any procedure, try to put wisdom, hikmah in Islam. Do you need extra bottle to be kept or not? And if needed, we must contact the lab to see where we can put it. Because sometimes you are going for rule of bacterial and you found that it looks like viral. And you need to rule out some viruses like herpes simplex or other. You are going to bring the patient again and do the procedure again. It is very often, okay? So this is a very important point. Of course, the latex test, if the patient was given any antibiotic, even single dose, because single dose sometimes they can make the CSF clear, but still there is meningitis. So latex test will detect if you started already, because we give instruction for any clinic or outside the hospital. If you suspect that your patient has meningitis, don't wait. Give him the first dose, especially pneumococcal or meningococcal. Give him the first dose of antibiotic, and it is best to give before it the steroid, and then send him directly to the hospital. It works. As early as you give, it works. Because sometimes the family said, oh, we are going to the hospital, let us go by bus home to collect our things, let us do. So the recommendation is to give him the first dose in your clinic of high dose of CPN or ceftriaxone. And if you suspect pneumococci, you may need to give him also corticosteroid, okay? Thanks. Next.
Okay, Assalamualaikum warahmatullahi wabarakatuh. Can everyone see my slide?
Yes.
Okay. So first of all, I would like to apologize for the technical problems earlier. So today I will be the last presenter. So I will share with you guys about two procedures. The first one is venipuncture, and the second will be the IV cannulation. Okay. So venipuncture in pediatrics, or venipuncture also called as phlebotomy, is a procedure is used for withdrawing blood, of course. I think all of you is very familiar with these two procedures. So the indications for venipuncture will be blood sampling for many purposes I will share later, and also for short-term infusion. And of course, there are a few contraindications that we need to be aware, that we need to we need to avoid when taking blood from the patient, such as there are signs of cellulitis on the patient's extremity, presence of hematoma, presence of vascular graft or shunt, or venous fibrosis upon palpation. And then there are a few sites that is recommended for the procedure. The first, there are different sites for venous site, heel prick or finger prick. Heel prick and finger prick is actually specifically for infants or neonates. It is not routinely done in older children. So for venous site, the common site will be the antecubital veins or the veins on the dorsum of the hand. However, we usually do venipuncture at the antecubital veins because it is the least painful site for the patient. However, if it is still quite not possible to get vein access, we can try other sites such as the veins on the dorsum of the hand or other sites. For heel prick, which is usually done in infants or neonates, it is done for infant age from birth until 6 months. For patient older than 6 months, it is usually not done. So the location or the site that we can do heel prick is at the site of the heel, patient's heel. So as you can see from the picture, we should avoid the middle area because it is it has the medial plantar nerve and also the lateral plantar nerve. We want to avoid this area because it has nerve bundles. So we want to avoid injuring the nerve. And
Yeah,
for
thank you. It is very important. Please, just to interrupt because it is important. This is very simple, but sometimes we can cause harm, especially for infants and newborns. You are allowed to break in the lateral. In the middle, as you said, there is a bundle. Yes, I agree, there is a bundle and it will cause more pain. But at the same time, it contains fascia.
fascia.
If you use it to traumatize the fascia here, while the patient became elder, he feel a pain in his leg. And the most important also, they said, don't break one place in the same time regularly. I mean, if you are going to break the patient on his leg, so break the right leg on the right side, then on the left side, then go to the left, then go to the, and come back, make it a circular, because repeated injection in the same place also can cause many effects. And there is recommended cases of osteomyelitis if you are not doing a clean one due to the same. Okay. Thanks, Fatin. Continue.
Okay. Thank you, doctor. Okay, and then for finger prick is actually not usually done in infants and neonates. However, if we want to perform finger prick on the patient, we should choose the middle finger or the ring finger only, and we should avoid the little finger because it has a thin tissue which can cause severe pain to the patient. So these are the equipment that are needed for the procedure. First one is the sterile glove. Non-sterile glove. It is not necessary to use sterile gloves. Alcohol swab for disinfection. Butterfly needle. It is recommended to use butterfly needle for pediatric patients. Tourniquet. Syringe. 10 mil. However, I think 10 mil is quite a lot. Usually 1 to 5 cc syringe should be okay for pediatric patient accordingly to the amount of blood needed, and of course blood tubes according to what the purpose of the blood withdrawal. Cotton gauze swabs to after the procedure to clean the area after the procedure, and also the tape and plaster to secure the area. Okay, next. Okay, so it is important for us to know the correct needle size and color to use in patient. So usually in neonate patient, we use this. Actually yellow color, not orange. This one is yellow. We use for neonate patients. However, for children, older children or infant, we recommend to use the blue one. So the recommended needle size for pediatric patient is around 22 to 23 gauge. Try to avoid using smaller needle size because it can cause hemolysis. For example, if we use a needle smaller than the 23, the yellow one, it has high risk for hemolysis when we withdraw the blood. So the recommended size will be the blue one or the yellow one. Okay, now moving on to the how we approach the patient. Of course, first of all, we always need to practice hand hygiene, wash hands accordingly to the 7 steps that we learned last week. And of course, we have to introduce ourselves and then explain to the patient and the parents about the procedure and gain their consent. Of course, it's important to gain their consent about the for the procedure. Okay, now for the preparation and the technique part. So first we prepare the equipment. We use the butterfly needle, like I mentioned before, usually 22 or 23 actually, not 25. And then we collect the supply and then perform hand hygiene. And during this procedure, it's actually quite important for us to have an assistant. So if the first of all, we can ask the parent if they willingly to assist us for the procedure to hold their child. However, if the parent will do not want to cooperate, so we can ask our colleague or any other person that is has the experience to help us to immobilize the child. So as you can see here, so during the procedure, the child will be on the table or the bed, and the 2 persons in charge for the procedure should be opposite to each other. So the one who is going to immobilize the child will be on the other side, and the one who is going to do the procedure will be on the other side of the bed. As you can see, the person who is going to immobilize the child will hold down the child by using one hand to support the child's head and the other hand to hold the child's hand or the arm that we want to withdraw the blood from. And then put the tourniquet on the patient about 2 finger width above the vena puncture site. So from this picture example, we want to withdraw blood from the antecubital site. So we put the tourniquet here. However, for infants, smaller child, we usually use elastic rubber to use as tourniquet because the tourniquet sometimes can be quite big, so it cannot really apply enough pressure to for the patient. And then after we apply the tourniquet, of course we need to we put our glove and then attach the end of the wing infusion set, which is the butterfly needle, set to the end of the vacuum tube and insert the collection tube into the holder until the tube reaches the needle. And then remove the plastic sleeve from the end of the butterfly needle. After we prepare the needle, we will disinfect the site for the injection with, usually we use the alcohol swab. And then allow the site to dry. So it is important after we disinfect the area and we allow it to dry, try to avoid touching the area because we already disinfect the area. We don't want to introduce any other infection. And then after we allow it to dry, we use our thumb on the non-dominant hand to draw the skin tight so that we can see the veins clearly about 2 finger width below the vena puncture site. Okay, and then we insert the needle. After that, we push the vacuum tube completely onto the needle. So when we withdraw the blood should begin to flow into the tube, as you can see through the in the picture. And then fill the tube until it's full or until the vacuum is exhausted. If filling multiple tubes, carefully remove the full tube and replace with another tube. So this is actually after we see the blood flow, we can fill the tubes needed for the tube, the blood tube that we need for blood specimen. Carefully remove the full tube and replace with another tube. Okay, and then after the required amount of blood has been collected, release the tourniquet. So after we finish the procedure, we remove the tourniquet and then remove the needle carefully and then place a dry gauze to clean the site, the vena puncture site. And then ask the parent, or if the patient is older, we ask the patient to apply pressure, continue to apply pressure on the injected site, injection site. Okay, so after that, remember to always dispose sharp needles into sharp bin to prevent any needle injury. And then properly dispose every other equipment, and always remember to label the tube correctly with the patient's name and identification number and the date when the blood was withdrawn. So after we do that, we put adhesive bandage at the site, and of course after every procedure, we perform another hand hygiene. Okay, so this is what I mentioned, the blood tubes. This is actually according to manual I get online. So the color, actually every color of the tubes has different tests. So if we want to send for full blood count or full blood picture, we need to put the blood in the purple tube. For renal profile or liver function test, we use the yellow one. For light blue is for coagulation profile, APTT, PTT or INR. If you want to check for glucose, venous glucose, we use the grey bottle. Okay. And okay, the last one is the complications of the procedure for vena puncture. Patient can have hematoma and nerve injury. So vena puncture procedure shouldn't be too painful. So if patient have severe pain during the procedure, it means we need to suspect nerve injury to the patient. Nerve injury, yeah. Okay, and then we can also accidentally have arterial puncture. So arterial puncture. So if this happen, we need to remove the needle immediately and apply direct pressure to the injection site for at least 10 minutes. Because as we all know, arterial pressure is higher compared to venous pressure. So that's why it has higher risk of continuous bleeding for if arterial puncture occur. And patient can also have syncope from blood withdrawal. Okay, so that is all for vena puncture. Next, we move on to the peripheral cannulation, or we call as IV cannula. So what are the indications for peripheral cannulation? So if you want to perform repeated blood sampling, for example, patient with dengue fever, we want to continuously monitor their platelet level. So it is easier for us to just put IV cannula rather than do vena puncture every time we want to withdraw the blood. So it can make our job easier and also can reduce pain to the patient. And of course, for IV fluid administration, for IV medication, chemotherapy, for parenteral nutrition, blood products if you want to transfuse blood or any blood products, and for contrast agents to inject contrast agents. For contraindications for peripheral cannulation, including if there is any broken bones or injuries at the site that we want to put the venous access, if we suspect compartment syndrome on the extremity, any swelling or edema present, there is the site of previous infiltration on the same extremity. For example, if the patient already have a IV cannula on the right side, so we need to avoid putting the venous access on the same side. So we can use the other arm, or we can use put proximal to the previous side, or if there are any open wounds or broken skin on the side. Okay. So these are the equipment needed for the procedure: non-sterile glove, tourniquet, a syringe, gauze for cleaning purpose, cannula, the IV cannula, saline or heparin solution for flushing, transparent dressing or tegaderm, tape to secure the cannula, and bandage roll also to secure the cannula. So these are the the size chart and the color for available. So for a neonate patient, usually we will use the yellow one. This. For pediatric, we use blue cannula. So these two are the most commonly used for pediatric patients. So it is important for us to know the higher the gauge size, the smaller the needle size will be. So we use 22 or 24 needle size. Okay, so for sites of venous access, it is actually quite different from venipuncture. So for venous access, usually we will try to insert the cannula at the dorsum of the hand because it has the basilic vein here, the cephalic vein, or the dorsal venous arch. So usually we want to access this vein because it is easier for us. And there are of course other sites such as the antecubital, the great saphenous vein, external jugular, and the scalp vein. For pediatric patient, it is actually not recommended to put at the ankle or at the foot of the patient because it can restrict patient's movement. So it is important for at least try to get venous access at the dorsum of the hand. So I have actually prepared 2 videos, but you can watch it later. So actually, so just to summarize from the video, so how the technique. So of course, the important one first, we need to practice hand hygiene, introduce ourselves to the patient, and gain consent and explain to the patient about the procedure. Okay, and then starting the procedure after we prepare all the equipment and we gain consent from the patient and the patient's parents. So we place the tourniquet over patient's non-dominant hand. Actually, it's recommended for us to insert the venous access at the non-dominant side. So for example, if the patient's dominant hand is on the right hand, so try to gain access on the left hand so that we do not disrupt their daily activity. So place a tourniquet just to make the vein more visible, and then select a site for the IV cannula insertion. After we gain after we get the suitable site for IV cannula, we apply antiseptic solution and let dry. So just the same as before, we apply alcohol swab and then apply and let it dry. So once it's dry, avoid touching the area or repalpating the area. Okay, so using the non-dominant hand, our non-dominant hand, the one that we didn't hold the needle, we stabilize the vein. Okay, and then we apply traction to the patient's skin. so that it is easier for us to insert the needle to prevent the needle going deep. And then angle of entry, it is important to know the angle of entry is about 10 to 25 degree for superficial veins. So upon entry, once we put the cannula, blood should appear in the cannula, which we call as flashback. We can see the blood moving up. So once we see the blood, okay. However, okay. Upon entry, blood should appear. Okay, what we call as flashback. However, if there is no blood appear during the insertion, so we should withdraw the IV cannula and then try another attempt. Try again without actually removing the IV cannula from the patient's skin. Means that the needle should be still within the skin. Just remove slightly. Okay. After gaining access and removing the needle, if we want to take any blood for blood sample purposes, use a syringe to draw the blood. So if not, we flush the cannula with saline or heparin solution, and then we close the IV cannula with the cap, and then apply tegaderm, and secure with tape. It's important to write date and time of IV cannulation, so that because we want to change the cannula every 5 days. So this is what I meant from the procedure. So you guys can look at it. So this is the picture. Okay. So for this one, like I mentioned before, date and time of cannula should be written. For older children, we can use tourniquet. However, for infant, because their hands are small, so we can apply compression just by flexing their wrists. Okay, and then frequent assessment of the cannula site should be done because we want to monitor any complications. So these are the complications that can occur during or after the procedure. Patient can have pain or failure to access the vein, which is also common if the technician is not experienced. We can also accidentally have an arterial puncture similar as venous puncture, hematoma, patient have bleeding, or the severe one can cause thrombophlebitis or extravasation. So what is actually thrombophlebitis? Thrombophlebitis is actually a formation of blood clot in the presence of venous injury, as you can see in the picture. Okay, so how can we actually know if patient has thrombophlebitis? Patient will complain of acute onset pain. There will be swelling at the injection site, and the site will be warm and erythema. So how can we actually manage? We can flush the cannula regularly and replace the cannula. Or we can consider resite the cannula, means we replace the cannula with other site. So this is the visual infusion phlebitis score. It has 0 to 5. Okay. The next one is extravasation. So what is extravasation? It is an unintentional leakage of medications or vesical fluid from vein to surrounding tissues. So how can it actually occur? It can be due to cannula piercing the vessel wall or increased venous pressure. So the clinical features actually depends on grading. I will share to you. So how can we manage? Stop the infusion. And the management is actually also accordingly to the grading. So this is the grading scale for extravasation. It has 0 to 4. Okay. So this is so from the picture here, This is actually grade 4 because patient have necrosis. As you can see, necrosis, and this is also stage 4 because it has skin breakdown. Okay, so how do we manage? For every grade, it is important to stop the infusion, of course, because the infusion is the one who is causing the extravasation. Okay, so for grade 1 and grade 2, it's actually quite similar. We stop the infusion, remove the cannula immediately, and elevate the limb. For grade 3 and grade 4, it is quite different, but it's same. So we stop the infusion, remove any constricting tapes, and leave the cannula in situ until any attending doctors or specialists come to review the patient. And then commence irrigation within 1 hour from the extravasation onset. Of course, before the irrigation, we need to give appropriate pain reliever to the patient because patient have severe pain. And then apply non-occlusive dressing and elevate the limb. For grade 4, it is actually quite similar to grade 3. However, we can refer to plastic team because as you can see from the previous picture, patients have necrosis of the skin and skin breakdown from the extravasation. So that is all from me.
Good. Hoping inshallah you can memorize all that presentation and put it in your clinical practice soon, inshallah. You need to ask your colleague any questions.
I have a question. How do we reduce the rate of or the incidence of thrombophlebitis?
Yes, it is very important, of course. Most of the units, especially in ICU units, are making incident report for any thrombophlebitis. It is infection control issue. Okay? Infection control. So infection control is the top. And the extravasation also is malpositioning. So if to take care not to move the cannula, not to be dislodged, especially if you have irritant medication. So this is the top 2 important, which you must take care about it, please. Of course, to be surveillance for your cannulation and like that, and the take place is the most important, because if you pick the leaking or extravasation early, you can protect the patient. In some cases, it will be sloughed the skin and make a bad cosmetic things, especially if for ladies. So take care about the ladies. And sometimes it will cause medical legal issue. Of course, with time, you must know how is the concentration of the drug which can be used in peripheral line, because one of the causes of extravasation is using concentrated medication with high osmolarity, like dextrose. The maximum dextrose we can use as a peripheral 10, 12, like that. But if you came to 12.5, you must go for central line because it will extravasate. And it is very painful. Also calcium is very painful and very traumatic. Okay. Any other questions? Okay. Fatin, are you the last one to present?
Yes, doctor. I'm the last one.
So what about the remaining procedures?
About the question,
What about the remaining procedure and the one who didn't present?
What procedures you mean, doctor?
I think the procedure listed you give are already been covered.
Not enough. I send you a lot of procedure also. Another.
We have covered in the first session.
Oh, so this is the second batch.
Yeah.
Okay, so you need to make correction for all and make it one file and drop it to me and to Farah, please.
All right. Noted, doctor.
Okay. Okay. You are welcome. Inshallah, Allah let me happy to see you more, inshallah, professional. And see you, inshallah, apply the knowledge which you got. Okay. Assalamu alaikum wa rahmatullah.
Waalaikumsalam.
Salam.
Waalaikumsalam. Thank you, doctor.
You are welcome. Assalamu alaikum.